Hey everybody, welcome to the Neurodiversity University Therapist Hub. I'm super excited to welcome you today to our live CE event. We are very excited to welcome Dr. Jeremy Schumann to talk to us today about making exposure and response prevention for OCD safer for our autistic clients. Just a couple little housekeeping things before we get started. First of all, of course, just kind of stay logged in for the session. We will give you your link to the evaluation at the end of the session. That is what will allow us to send you your certificates. And so we'll put that in the chat at the end of the session. Feel free to participate via chat or unmute yourself if you have any Q&A. You can always message me directly. I think with the way that Jeremy's got it set up, he sees his presentation, but if you do a visual cue for him, he may not see that. So just make sure we're doing that other way of connecting there. And then, of course, we will save some time at the end for discussion. So we'll have time probably, if you have certain questions and you want to throw them in chat, we can try to integrate those, but also we will make sure that we have that time at the end as well. So with all of that, Jeremy, I will turn it over to you.
Okay, thanks so much, Emily. I've been really looking forward to giving this talk, so I'm excited to have you guys here with me. And for the folks that get to watch the recording, appreciate your time and attention as well. I'm going to back up what Emily just said, that I have the settings all weird where I can't see the live audience. So if you guys have questions, I'm going to ask you put them in the chat, which I also can't see. And for Emily, for you to interrupt me with those questions whenever it feels convenient so that we can kind of work them in to the flow of things as we go.
Perfect.
And so today our talk is going to be about making exposure response prevention, ERP, which is the gold standard treatment for OCD, safer for our autistic clients. We know that there's a ton of overlap between autism and OCD, with something like 17% of autistic clients also having OCD, but that number might really go up as high as 35%. It's hard to get perfect statistics on that. And there's a lot of overlap in the observable behaviors, but we usually want to take a different approach with regard to intervention or accommodation, depending on what the source of these behaviors are. So today's talk, I would have loved to title this Neurodiversity Affirming OCD Care, but that is such a huge topic, and it really involves teaching ERP from the beginning. And so I'm going to be assuming that you all can learn a little bit about ERP, or you already have if you're coming to this training. And I'm going to talk mostly about people who know how to do ERP with non-autistic clients. How do we make it safer for our autistic clients, as opposed to thinking, how do we make this in all ways neurodiversity affirming? So it's going to be a little bit of a critique, a little bit of modifications, and I hope you guys enjoy. So we're going to start with understanding ERP and its role in OCD treatment. There's a lot of approaches to treating OCD that if you Google, or you even run a PubMed search or an EBSCOhost search, you can find a lot of different studies that are clinicians trying to treat ERP from a variety of different approaches. Not all of those approaches have the same evidence base. These are the top 3 evidenced approaches, and the only ones that have applied to the American Psychiatric Association's or Psychological Association's Division 12, which does sort of these rankings of empirically supported treatments. So our top of the line, gold standard one, is exposure and response prevention. You'll see that abbreviated as ERP or E-RP or EX/RP. It's all the same stuff, just whatever trainer you go to. It has a really strong evidentiary base with more than 40 randomized clinical trials. That's like some of the best in all of psychotherapy research. It still only has the second highest level of evidence, according to the APA Division 12, like that strong support as opposed to very strong support. That's something that changed with the introduction of the Toland guidelines back maybe about 10 years ago. It's very, very hard to get up to that absolute top level. But it is considered our gold standard in OCD treatment because it's got more evidence than anything else, and we know that it works. This is a therapy that uses behavioral principles. We face these triggering, scary situations. We abstain from the compulsions and safety behaviors that were purportedly keeping us safe. And so then we experience safety paired with that aversive stimulus, and that generates new learning. An offshoot of this is a form of ERP where the therapist only meets with the parents or the supports of the person that we're trying to help, where we teach them to remove accommodations that we're supporting the person with OCD's ability to do compulsions. And by removing those accommodations, we get these naturalistic learning experiences that there was no danger when I wasn't able to do my safety plan. I still turned out okay, so I guess everything is okay. So this is what the focus of the talk today is going to be about. We do have options though. Acceptance and commitment therapy also has some support. It's been evaluated by APA Division 12. They put out their request for evaluation more than 5 years ago. They have a pretty large body of evidence, 15 randomized controlled trials, but this is still considered modest research support by the APA. And I can't see all my notes because of the screen thing again, but what they need to get the more strong support is to have more independent labs verify this, because they tend to have the same labs over and over again give results. So they think that there might be researcher reliance. And then also we need larger studies. Some of the RCTs have been pretty small. And then finally, we have inference-based cognitive behavioral therapy. This is a therapy that's been around since the 90s, but it's really only popular in the US over the past 5 years or so, or 4 years or so. It's got a much smaller body of evidence with only 4 randomized clinical trials and 1 current open trial. And they're trying to demonstrate non-inferiority to exposure and response prevention. That means that the effect sizes are not clinically significantly different from an equal dose of treatment. And after doing that, then they'll write a what's it called, a meta-analysis of all their study results, and then apply to Division 12 with that. Maybe they'll get modest support with that. Their first publication about the non-inferiority trial could not prove non-inferiority. Now, that's not the same thing as proving inferiority, but it's not the proving non-inferiority that they would have wanted to do. But you know what? Multi-site trial, you keep going, you keep collecting data, and you see what comes of it. ICBT is a purely cognitive intervention. So ERP is our behavioral intervention. ACT actually uses a lot of the same mechanisms of action as ERP, because you have to go live your values-based life, which involves facing the triggers that you have been avoiding. In ICBT, we don't tell people live your values-based life and get better at tolerating the distress around these triggers. We elucidate how the obsession got constructed. And in a lot of cases, folks can learn how to not construct their whole obsession. They can see some of the thoughts that bridge off into these obsessional doubts and beliefs, and they sort of resist the siren's call, is what I like to say, to crash their ship on the rocks, to go make this mistake. They see some of those initial thoughts and they reground in the present moment instead of starting to invent what ifs. So all of these are approaches that have some evidence base. Again, we're going to talk about ERP today. ERP works based off of an understanding of OCD that is the appraisal model. So in the appraisal model of OCD, people experience a trigger, and then that trigger leads to intrusive, unwanted thoughts, images, urges. And then there is a maladaptive interpretation, a misunderstanding of the meaning of what those intrusive thoughts are, where we think I'm supposed to be able to control my thoughts, or they say something about me. They can't just possibly be random, scary thoughts. Those maladaptive interpretations lead to negative emotions. And then those negative emotions lead us to do maladaptive coping strategies, which are avoidance, avoiding the triggers, so we're not getting learning experiences about what happens when we face these things, and ritualizing, which they start as safety behaviors, where it's something maybe it feels like it made sense to the person at the time about how it's supposed to protect me from whatever maladaptive interpretation, whatever outcome I was afraid of. But over time, they just get negatively reinforced by the way that they reduce this negative emotion, and they can really lose their sense of purpose at all. And they just start to be something that I feel like I have to do. And it's sort of a primal feeling like it's not right and it's not going to be right until I won't be able to rest until I perform this in a way that feels just right. So an example of this is a trigger might be someone's using a kitchen knife, and this is a mom who gets an intrusive thought. What if I want to stab my baby with this knife? And they have maladaptive interpretation. The fact that I had that thought means I might lose control. Maybe it means I want to do this, I don't think good mothers would ever think like this. So she feels all these negative emotions, and then she avoids sharp knives and sharp objects, and she feels less anxious when she's not around the knives. She checks if her baby is okay all the time, as if she wasn't a good mom, as if she couldn't trust herself to keep her baby safe. And she asks her husband for reassurance, as if she doesn't know her own identity. And by doing that over and over again, we are just reinforcing that she is at risk. She's reinforcing for herself that she is at risk of losing control, because it feels like the only reason that the baby is safe is because I keep checking on it, because I don't touch the knives. So we intervene at this arrow right here. This is our same model: trigger thought, misappraisal, averse emotion, compulsive coping. We have two reinforcement loops where compulsive coping behaviors reduce negative emotions, so we get that negative reinforcement of the compulsive coping behavior, and it happens more and more. And we also have this more insight-based pathway where compulsive behaviors prevent the acquisition of new knowledge about what really happens when we engage with these triggers. So the way that ERP works is we are going to expose people to an aversive experience, or they're going to choose to expose themselves to the aversive experience. If that experience was really dangerous, then they would learn fear. If that experience was not really dangerous, it was just uncomfortable, well, did the person protect themselves from fake danger? Because if the reason that they feel like they're safe is they did some protection against fake danger, they're not learning that that danger was really fake. They will still get fear learning even though it wasn't dangerous. Or did they escape from the situation before the feared consequence that they're worried about could have ever possibly happened? Same thing, they can explain away, I was only safe because. So what we're doing in ERP is we're following this bottom line. We're exposing people to aversive experiences. Now, there's uncertainty in life, so we can't ever promise that things aren't dangerous, but we're encouraging people to take the kind of risks that they were comfortable taking before OCD showed up with an obsessional narrative about it. And then they're not protecting themselves from fake danger. They're staying with it long enough that there's no other explanation than it's safe. And that's when they get their safety learning. So this is how ERP works. Maybe you guys already are well aware of some of the risks when we take a model that assumes there is no danger, or assumes that people are going to be able to process this learning and change their mind about danger through these experiences. So let's take a look at some of those challenges. So first off, there are these siloed worlds between autism and neurodiversity. Now, I have to give us credit. Basically, in the past 2 years, this has really started to improve. I see it at ICDF. I see it on Facebook where other therapists are posting things. I see it in popular literature, on non-therapist Facebook sites or reels or things like that. People are starting to have more understanding. So I'm really proud of that. But it's true that we have few autistic leaders researching and teaching about OCD. So with the separation of these worlds, we have somewhat combating viewpoints instead of a cohesive piece of advice that we can give to everybody. We're working on that. My intent with these presentations that I give is to find that dialectic between these two perspectives, because both absolutely have merit. The part of the reason that there are few autistic leaders in the OCD world is because of all this CBT stuff and all the negative associations in the neurodiversity movement with CBT, and especially applied behavioral analysis, all the community trauma at the hands of behaviors. This is really valid. And if someone is like, I can't touch CBT because of other experiences that I had, my first thought is not, let's get you trauma therapy so that you can go back to CBT. Let's get you CBT-based trauma therapy, if that. My first thought is, okay, let me respect your experiences and your history, and let's find a workaround. I don't need to push on this necessarily, but at the same time, I really value CBT. We're going to talk more about guardrailing in a second here. Another challenge with using ERP is it just has any behaviorism really has a relatively high potential for coercion, where the therapist or the support system has the goal in mind, and we use behavioral learning principles to make this person's experience much easier when they do what's expected of them. And this teaches them not how to feel better in life, but how to be less of a problem to their support system. So it's something we're always going to be aware of. it has the potential to do fundamental change intent, which is like when we're working with autistic clients, we're not trying to get them to stop having sensory needs or to stop enjoying their special interest. These are things that are very fundamental and they're not really changeable. So if we are misunderstanding OCD and we're applying an OCD therapy to something that's really an autistic trait, then we are trying to fundamentally change that person and we're going to have a really bad prognosis. All we'll ever get out of that is coercion or learned helplessness, which is our next bullet point here. When someone has repeatedly seen that there's no way for me to ever get my needs met, they will reduce their attempts to get their needs met, but their stress response doesn't necessarily come down. That's what learned helplessness looks like. If we see this behavioral habituation where we no longer see a response to an aversive stimulus, it doesn't necessarily mean that all the subjective distress behind that has cleared up. So learned helplessness is a potential risk whenever we're doing behaviorism. And finally, this goes right hand in hand with coercion. We can struggle with getting the patient to really identify their own goals when their caregivers and their support system may have a lot of goals for them, and the patient may feel like they are a burden, or they may feel kind of rigid about being in conflict with their caregivers about some of these things and not want to make their own goals. So then we might fall back on goals that are really not respecting the agency of our client when we are doing this behavior change kind of stuff. Other challenges. It's kind of tough to do a functional assessment to make sure you're telling the difference between what comes from OCD and what comes from autism. We have to look into the function of the behavior. Is it making the person feel better temporarily, but making them worse off in the long term? Or is this something that is really an effective coping strategy for them in the long term? And there was going to be no way for them to cope without something to replace the function that was giving. That can't really be done in like an assessment. One of the most common questions I get is, what testing form, what handout can you give that will help people discern an OCD behavior from an autistic behavior when it comes to repetitive behaviors? And the answer is you have to do a functional analysis. You have to do interview. You can't just look at what the specific behavior is to tell how. You have to see how it works for that person to understand that. So it takes some expertise and some training. And then even, when I supervise folks, it's not something that I can just explain in one case. You have to see case after case after case, really get the flavor of it and be able to discern it from a highly experienced place. Other challenges are that autistic people might have slower processing or might have different learning needs, sensory sensitivities, executive function difficulties, or intellectual support needs. That means that this therapy might go slow, or that means that some of the insight that comes along with this therapy might not ever happen. And anxiety sensitivity is a big part of treating OCD because we have to help people be okay with feeling distress because they're trying to escape from distress. Well, anxiety sensitivity can be very ego-syntonic, meaning it agrees with the person's identity. For both people who are traumatized, which most of all of our autistic folks who have grown up in a neurotypical world have some degree of trauma and might have some rigidity around, you shouldn't be making me feel overwhelmed and anxious because of that. And also people who are really rigid about their ways, rigid about things being predictable and the same, they don't want to feel anxious and they don't want to feel distressed. And so that's going to be our artistic community too. So trying to teach that to people who have really good reason for not wanting that can be a challenge, but I still think it's worth trying. And this is like an evidence-based therapy that can be kind of manualized, and there's a lot of work to do. I could very easily fill up a 90-minute session with content doing exposure therapy, but folks don't always want to prioritize this kind of therapy. Folks come into therapy thinking they're going to have this warm relationship with their therapist, which they absolutely can with an ERP therapist still, but when life gets in the way and they want to talk about other things and they want to vent or info dump or build a positive identity, ERP therapists might say, that's not what was in the plan for today. We have to spend our time on doing the exposures or you're not going to get any better. So that could be a challenge too. You might need a lot of services. If you're doing this, you might need supportive therapy in addition to this. And lastly, when we do start to bring in adaptations to ERP to make it more friendly, it can run the risk of being really infantilizing. Rather than making it sort of optimized for the individual, we take these adaptations that were designed thinking about a population, and that population has about 50% intellectual disability, 50% not. So some of these suggestions aren't really that applicable across the broad swath of people. So I'm trying to take a look at some of that today. Despite all these challenges, I keep saying that guardrailing isn't the answer. Guardrailing is when we prevent people from accessing things because we think it's going to be too much, it's going to be too difficult. We're trying to protect them. So that might be you are working with a student and he's a senior in high school and he starts talking about going off to college, but he's been having panic attacks and meltdowns, and you think, oh, he's never going to be able to do the college plan that he says that he wants to do. We don't want to tell people, no, you're not capable of those things. We want to help build the skills so they can get there. And along the way of building the skills, often their trajectory will shift a little bit as they see what the next right thing for them to do is. But we don't want to take those pie in the sky ideals and get rid of them for people. So yeah, guardrailing is preventing people from doing the things that they feel that they have potential to do. And I get why. There's a lot of internalized ableism that autistic people can take on, not just autistic people, anyone who with a chronic disability. And then they feel like all this should, must thinking about success or trying the hardest thing. So we want to give people options and protect them, but that's not the same thing as treating them like they're incapable, treating them like they're too fragile, and guardrailing. So we don't want a guardrail because ERP is the gold standard for many reasons, not the least of which is that it really works. And anyone who's done this work for a long time tends to like gravitate towards these interventions where you see immediate and powerful, potent effects with your clients. I know a lot of EMDR therapists love EMDR for the same reason that like within a session, you can see a person make a change and a difference in their life. It's really remarkable to see someone who has avoided something their whole life make a huge change in just a matter of weeks. And we don't want to withhold that from people. Also, when we're actually doing ERP well, when we're achieving our learning goals, staying within the window of tolerance, ERP doesn't feel coercive. It feels really empowering. It feels client-led. It feels like achievement and seeing the best in yourself, and it's positive identity building. It's very self-esteem building. It doesn't have to be so ugly and coercive and a fight. So we don't want to assume that it's going to be that way when it could feel this other way. It's ableist to force someone to do something that's beyond their capacity, but it's also ableist to not presume competence and offer the best available strategies. We see in a lot of studies about OCD that clinicians who are afraid to do exposure get worse outcomes. So I challenge folks, or I ask folks when I'm training them to work on their own pre-assumptions about what ERP might feel like, and to really, let's learn from our autistic clients and do some bottom-up processing. Let's see what happens when we bring some of these things into the room and do some data collection and not fill in all the blanks for our clients. We don't want to make these mistakes that neurotypical people are getting guidance for their therapist to challenge their exposure phobia. And then also, one of the big complaints about CBT is this whole CBT is just teaching you to gaslight yourself. There's real systemic problems, and we're saying, hey, it's okay. Just tell yourself it's okay, and you'll feel like it's okay. Well, in OCD, your brain really does lie to you. It tells you you can't trust what you just experienced. It tells you that you are not who you think yourself to be. So this is not the same as cognitive therapy that would be minimizing minority stress. This is building trust in self through behavioral strategies, much more than from any sort of like cognitive restriction where you're trying to argue with something. Arguing with OCD doesn't work anyway. So I think we're good to do CBT techniques, to do ERP for OCD if the outcomes that we're always shooting for they're never these coercion, they're never these just behaviorally defined things. We want to see that actually obsessions end, not just the behavior return to normal, but the reason the behavior returned to normal is the person doesn't believe those thoughts when they pop into their mind so much anymore. We want to see desensitization to highly aversive stimuli. And the main one in OCD that we're going to see is like disgust, where folks could learn that they're just supposed to tolerate disgusting things. And that is part of the treatment. But also there has to be some degree of shared responsibility between like the support people, the context, and the client who's got the disgust hypersensitivity, where the person is getting accommodations for their disgust sensitivity, and also they are desensitizing to those disgust feelings. And they can not just hide the fact that they're disgusted, but slowly approach until they feel literally less disgusted by things. It doesn't happen for everyone. It does happen for a lot of people, though. And we should see mastery of avoided contexts, mastery versus white knuckling. If someone is miserable, but they can be dragged through an experience, it's not the same thing as them getting something out of that experience. We only want to see this avoidance changing when the person is feeling like, again, the obsession is ended, any sensory stuff is desensitized, and now they're feeling like they have a mastery over this context, not that they're a slave to it. And this is going to always require some balance of environmental flexibility and negotiation. So, or I say environmental flexibility, but really it's going to be more the autistic person who struggles with need for sameness and rigidity. They're going to have to do a lot of work, generally speaking, to feel comfortable with this negotiation where there's a back and forth and both sides are giving a little bit. So how to do the adapting? There are a lot of common suggestions in the resources that in the resource page that I sent in. There's a book by, who's it, Russell and Jassy and Johnson, I want to say. They're a UK-based group, and Amita Jassy's done a lot of writing on this. I really like her writing on it. She's got an OCD for autistic folks workbook that I think is pretty decent. I borrow pretty heavily from their suggestions, but their suggestions, they didn't invent the wheel either. There are a lot of very similar protocols for these adaptations. So I'm just kind of borrowing from all of them and melding them together. And what I hope to do is to not just think about how to make the outcome of the behavior reduction effective, but how to bring in, from that last slide, the really ending obsessions as we're dealing with each of these things. So we're going to go through each one of these with a slide on its own. Meet communication preferences, have sensory and STEM-friendly office, maximizing predictability, enhancing agency and positive identity development, discerning OCD from special interests, stimming, sensory intolerance, emotional intensity, accommodating how autistic folks typically have a slower pace of habituation and a slower processing speed, involving caregivers, and finding motivation, which I like to say, make it make sense. The motivation has to be, I want this, or we prefer it to be, I want this. So all of these are these adaptations to ERP that are going to support our autistic clients. But more than that, this is universal design. These are things that are going to help neurotypical, or I don't love that word, allistic clients, or any client. These are just generally ways that ERP could steer wrong. I don't see them entirely as unique to OCD in any way. Even stuff like special interests or stimming or sensory stuff that is pretty commonly associated with autism. People get hyperfixated on things. We don't want to call that OCD. Stimming is not unique to autism. Sensory intolerance is not unique to autism. Emotional intensity is not unique to autism. So I think when we take these things seriously, we look at this less as an adaptation for autism and more as just ethically providing ERP and not being lazy about it. ERP as a behavioral therapy can be very easily manualized, and then we can lose our clinician brain and act instead as a technician. And as a technician, we got the diagnosis and we're following the steps. When we are a clinician, we are thinking about the individual in front of us and adapting the evidence-based practice that we need according to our clinical wisdom and our client preferences. And doing that, we're doing that same thing for every single client. So we can bring these kinds of principles in universal design. So our first point is communicating effectively. Now, when I see other presentations on this, we see a lot, don't use metaphor. Don't use language that's anything other than concrete, simple language. I try to go a little bit behind you, so you have a lot more bullet points than that. So first off, I'll say allow comfort in communication, allow people to have long pauses while they're thinking about things. Someone might say, that's avoidance. We need to get to the point of it. You're doing a compulsion in your head right now, but we might need to allow people to pause so they can process and they can communicate. And then allowing things like tangents and info dumps where it feels like it's off topic, but this is the thing that's going to help the person regulate their immune system, their nervous system. If they're constantly being redirected back to the task at hand, back to the task at hand, back to the task at hand, it's going to be jarring on their monotropic preference nervous system. And we're not going to get as much learning when someone's outside their window of tolerance in that way. Same with low eye contact or allowing people to move their body while they're doing sessions, which typically are not seen as ideal communication. Also using resources like AAC devices. I'm sure you guys are all familiar with this stuff, allowing people to write to respond or text to respond, doing telehealth when people aren't comfortable communicating because the office is so overwhelming, or even doing things like using gaming. There's a lot of geek therapy where folks meet inside of video games. I think you can do psychoed pretty well there. There are ways you could probably incorporate ERP into video game therapy, but you probably really need to engage in the real world to do the actual ERP. But that doesn't mean that we can't do the psychoed and the stuff that takes a lot of heavy communication and sessions between the ERP sessions where we're consolidating learning with some gaming in the background, if that's what's working for your client. And then also don't overinterpret nonverbal communication. So if you are doing an exposure and your client seems stoic or plain-faced, you might think, oh, they're not really feeling much distress. But we know that there can sometimes be a mismatch between what's going on the inside and what's being displayed on the outside, a mismatch between verbal and nonverbal communication. And I'm not talking about non-speaking communication. I'm talking about mannerisms and facial expressions and gestures and social skills and things like that. So let's not overinterpret. We always want to get their verbal response so we can understand what's going on for them and give them adequate time to really think about what their verbal response is going to be, even if that verbal response is non-speaking. So to come to that main point that I see in a lot of the presentations, should we use concrete literal language or do we use an eloquent bouquet of metaphors? It really depends on your client. Again, with that 50% of autistic people have intellectual disability, concrete literal language is going to be really helpful for them. But then also we've got hyperverbal autistic people who are going to feel infantilized by that and who are going to miss out on their own healing that can come through the development of metaphors and creative expression around their learning. That's such a valuable way to learn, is to make something your own through creative expression. So the better idea is to develop a shared vocabulary. The metaphors you use tend to be the same metaphors over and over and over again. I've got a client I'm working with right now where we talked so much about Fallout Boy, and it's just, that's the language that we've used to describe like who is sensitive and open to other people's perspectives and not because of associations that she has with Fallout Boy. So it would seem like I'm using a metaphor in a way that's bizarre, but it's like, it's her language. So it's the right step for her. Still with that, it's usually valuable to do things like write session summaries of important content so that we can make sure that we got it in the simplest possible language in a way they can take home and study. And we write down homework for folks each session so that they have clarity about what we're asking them to do. It's really useful to use multiple inputs. So not just their auditory, where they're hearing new knowledge, but create visuals for concepts, create art with your clients around these concepts, put visuals in triggering spaces where we're asking them to do a response prevention plan, put something that facilitated their learning in session in a visible spot so that they have that cue, but also it kind of reminds them what they were feeling like when they were with this object or image last. And that can help in ways that just the words aren't going to help. And visual depictions of time are another common communication strategy. So that would be like having a session agenda where maybe we use a clock where we color it, or we put some colors and space out words so that we are making a visual representation of how time will be spent in the session. And another piece of communicating effectively is going to be that we don't want to assume that any of the response prevention plans that we come up with are going to be clearly explained in words. So we're going to want to role play and rehearse any behavioral prescriptions that we're giving people. So for an example, someone has been scrubbing their kitchen counter repeatedly. They do it 10 times and they do it for half an hour is what it takes to do. And we say, just give it a quick wipe down. People don't necessarily know what a quick wipe down is. Again, that seems very much like universal design to me, but especially for autistic clients, they might get very frustrated by not having a clear depiction of what that is. The way around it is not more words, it's to do the action together and to let the person learn it in their muscle memory, not just in their semantic memory. Another piece of communication that could be helpful is folks who work with autistic folks often already know about social stories. Social stories are these specifically worded stories that tell what happens in a situation from beginning to end to increase predictability. And we can repeat the same simple story over and over again to really deepen learning on a specific procedure that we want people to do. That maps really well on the response prevention plans. When we're building response prevention plans, we can write social stories about the plan for the way that we're at right now, and we can rehearse those every day. And then working with autistic people, we have to be aware of interoceptive differences. Emotions can be experienced really intense, or they can be experienced kind of muted. And that's our alexithymia concept. I don't know what emotion I'm experiencing. Maybe I can tell that I feel really off or agitated. Maybe I really couldn't even tell you that I was noticing that. Well, when someone is in that state, their ability to rate how distressed they are and monitor that distress coming down over time it's gonna be less useful as a tool. In ERP, we often are trying to trigger their SUDS rating and need it to decline in half, and then we move on to the next task. But folks might struggle with quantifying it. They might feel like they're not being honest when they give numbers. So some things we can do are use high, medium, low. That might help. Or use a personalized scale like this one. And I got permission from Nicole Morris, who does OCD Family Podcast, to use her graphic that she's shared in the OCD Facebook group about this. So it's not that you have to use the Pokemon one. It's that as an art project, while you are doing psychoed, you build your own, however you want to do. And then I just wanted to make this comment because I think this is like the way that therapy really happens is we just don't need to be so perfect. So as I look at this one, I see happy going through concern, but then when we get to panicky, I don't know, he looks mischievous to me, and overwhelmed. I'm not sure that is like more anxious than this panicky one. And crisis, he's angry. He's not melting down. Maybe that doesn't look like me. That won't matter. What will happen with your clients is they will pick whichever Pokemon means high, medium, and low, and you will come up with your own shared vocabulary. It's just bridging the gap between I got numbers and I need you to use them to what the client's own language is going to be. And it doesn't matter if we actually use 1 through 10. We can say, I'm feeling like Mewtwo or I'm feeling like Jigglypuff, and that works just as well. After making personalized scales, we still might decide, we don't really want to quantify distress reduction instead. And we might choose to just track other variables like time spent or repetitions of the exposure. Now, when we do those, we are moving away from distress reduction and into compliance. And we start taking a risk when we do that. Again, I don't guardrail people away from effective interventions. I meet them where they're at. I show up with sensitivity and ask the question and stay curious. And does it take risks? Yes. Also, it takes risks when we refuse to like track variables and hold people accountable because they could have gotten so much better and we didn't give them that. And that is not a mistake we want to make either. So when this doesn't work out so well, we might just do away with these SUDS ratings in general, or we can also make referrals to occupational therapy, or we can use some of the interoception measures like Kelly Mahler's interoception training is really excellent, and we could teach basic emotion mapping to our clients without referring them to OT as well. Next one is making a sensory and STEM-friendly office space. This is going to be for any kind of therapy, right? And this is also not unique to autism, but anyone who's in our world probably knows about this. So encourage stimming in session, offer the stim basket every single time. So first of all, have a basket with a lot of stims and offer it, not just assume that since they took it last time, they know they can have it this time. Encourage people to stim, especially if you know that it works for them. Might be a good idea to have an office, if you can, with soundproof walls, so we're reducing distraction coming in, but also so that people can do verbal stimming and not distract their neighbors. We want to be aware of smell stuff that's often experienced really strongly. So no default perfumes. Don't put perfume in your office, or a scented candle, or a wax melt or anything like that when you have in-person clients who are autistic, until you've gotten their permission, because it can be really overwhelming for folks. But have options for Sense as a rescue kit for sensory stimming. Options for low or bright light or colored lighting, because people have different preferences with that. Some people can't stand the bright lighting. Some people, you put on the low lighting and they get understimulated and start falling asleep. You know what your client needs. Be cautious about white noise in your office. This is like a newbie therapist thing I see a lot when I'm training folks. And honestly, I don't always have the better answer for you. But if you could hear the private conversation that's going on in session outside of the door, you would put a white noise machine outside the door, so anyone who's walking by isn't going to be able to hear the therapy conversation over the white noise. Well, a lot of us have offices where we're kind of like jammed in with our neighbors, and even within another office, we can hear our neighbors' conversation, and we want to respect their privacy. Putting white noise within your office is not always an answer to that. People don't always habituate to white noise, especially autistic people. And you might have to ask questions about it and work through that, because your office might be a really unfriendly place by the sensory friendly intervention that you were trying to do by putting in the white noise. Give people the option they could wait in their car instead of coming into the waiting room if the waiting room is overwhelming. Make sure people are moving when they're learning, if they learn best that way. Collaborate with your client's occupational therapist for personalized recommendations about ways to meet their sensory needs. And just remember that new learning in ERP is not happening if someone's in a state of sensory overload. We want to stay inside the window of tolerance. What we get outside that window of tolerance is white knuckling and dissociation. Too low and they're too sleepy. Too high and they check out in a absorbed or a sort of like a amnestic almost way. And white knuckling, I explained before, is where they are going through with the exposure, but they're not really paying attention to what's going on in the room. They are just gritting their teeth and bearing it. White knuckling comes from you're clenching the steering wheel so tight that your knuckles turn white. And when you have that kind of tension, you're telling your nervous system, we are not safe. So you're not going to be building safety learning with new associations. So yeah, too much sensory intensity is going to prevent that kind of learning. Next thing we want to make sure is that we are thinking about how predictable the experience is for our client. We want to accommodate preferences for sameness and predictability and comprehensive understanding that are part of autism. So because autistic people have elevated baseline anxiety, that can very much be a support that helps them not get, launch off from starting at a 7 out of 10, launch up to 10 out of 10 really quickly, is knowing everything that's coming. And it also will support executive function struggles, where people do best when they're doing it the same way over and over and over again. They can learn the muscle memory of it. They can learn the protocol of it. So predictability is helpful for those multiple reasons. But at the same time, autistic people's preference for sameness can turn into OCD, because I want it to be this way. It's not this way. Am I disappointed but flexible? Am I saying to myself, oh, it's too bad. I really prefer it that way, and I'm going to have to deal with it being this other way? Or am I getting a not just right experience, NJRE, where it feels like I don't know what's wrong, but something is seriously wrong. And then I start coming up with these fear-based narratives that explain away, I need to neutralize this feeling or something awful is going to happen. So we are not going to accommodate NJREs, and we are going to accommodate that preference for sameness. Teaching clients to be their own self-advocate, so they conceptualize and understand their own case, so they are doing that discerning, is a really valuable skill in in allowing them to maintain that predictability while letting go of the NJRE. It's helpful to have each session have a very consistent structure, making a written agenda, visual schedule, like we talked about, scheduling in homework. So it's a good idea for folks doing ERP, again, without autism as well. Put it in your calendar. You put your appointment to come see me in your calendar. Put your homework practice time in your calendar too. Someone says, do you want to go out to dinner? I can't. I've got an appointment with myself already, with my support person who's helping me out already. And set alarms so you remember to do it. Same as we do with taking our meds or anything else that we've got to do. Helps it be more predictable. I'm not trying to memorize everything and fly by the seat of my pants. Explain and explore everything about an exposure as much as a client wants before attempting that exposure. Sometimes in OCD therapy, that would be seen as avoidance and delay, and maybe even trying to get rid of the anxiety before I do the exposure, which is not teaching me the distress tolerance that I would need to learn. But for autistic people, it's going to help so much with their willingness and their feeling of agency and not white knuckling through these things to be able to explore, where is this going to happen? What's it going to feel like? Let me have a tiny little dose of it. Let me visit it and then watch it on YouTube. And then we're not even doing the exposure today, but then eventually I'm coming around to being able to do it because I've asked all my questions and I've seen it from all the angles. In normal OCD therapy, we might treat those kind of questions as if someone's being like resistant or treatment interfering behavior. With our autistic clients, they've been called too much so many times over these kinds of questions. Let's try to do our best to treat those questions as curiosity and interest in this, and investment in the process, rather than treating it just as defensiveness and standoffishness, even though it can feel that way sometimes. And then anytime we're going to make changes to the way that session structure goes or the way an exposure is going to go, we're going to warn before so we can do this process of explaining and exploring. Also with predictability, we need to involve support people in therapy because they're going to go home to their support people and they're going to say, this is what I did in therapy, this is what I'm trying to do. And if their support person isn't having a conversation with the therapist, they're going to be unpredictable in the response. They're going to say, I disagree with this, or I think your therapist really meant this. And to have that consistency is going to help the person feel safe in doing their ERP. And I want to just compare this and contrast this real quick with what we learned from inhibitory learning research as we move out of a pure habituation desensitization model of how ERP works into this more inhibitory learning model where there's explicit learning and there's sort of that latent learning. The inhibitory learning folks say that expectancy violation is the mechanism of action of ERP. You need to be expecting one thing, and then you get disconfirming evidence that no one told you it was going to be what happened. You experienced it firsthand. That they're saying that's the mechanism of action, and we should do it over and over and over again. So surprise, right? That's the mechanism of action, but our autistic clients like predictability. We can find somewhat of a middle ground in this. People have parts, right? They've got one part of them thinks that they're going to be okay. Another part thinks that they're going to be doomed. And they can kind of hold that ambivalence and do some of this work while we can still let that part that wants to know that they're safe get the information that it needs in that. Another concept with inhibitory learning with that element of surprise is they don't want to, they suggest instead of doing hierarchies where you start with low-level adverse exposures and work your way to the most difficult ones, they say that after you get buy-in, we should have an exposure menu so that it's unpredictable if I'm going to be experiencing a lot of distress today or just a little bit of distress today. Then what I'm getting okay with is this uncertainty about how the experience is going to feel, and I'm learning to trust my resilience. Whether it's low or whether it's high, it doesn't make that big of a difference at the end of the day. But maybe that's not our best route for our autistic clients who really do prefer predictability and maybe want to go up that ladder because of their delay in habituation and also just again for that predictability. There is not empirical testing on this. Some researcher out there hopefully will test that one because there's a lot of good inhibitory learning research right now. I don't see it combined with autism research, but it's interesting.
Hey, Jeremy, I have a question.
Yeah.
Can you talk a little bit about, I'm just kind of curious, like what might an agenda in a session dealing, focusing on the, what that schedule might look like within the within a session? That was not a very
Yeah,
clear
so we
question,
might.
but hopefully you got what I.
I don't want to pull off my screen share to pull up an example one, but like you can imagine, first 5 minutes is greeting, and then we're going to do 10 minutes of looking through your homework, and then we're going to do 30 minutes of an exposure practice, and then we're going to do 10 minutes of free time, which could be info dumping, could be consolidating learning, it could be whatever the person wants to do, and then their homework written at the bottom of it, and they can take that home with them, something like that. And I might jot it down just on like a blank piece of paper and hand it to them during the session and have them collect those kinds of things in a folder. Sometimes folks will bring a notebook and I'll jot down for them in their notebook, something like that, or have them jot it down depending on their functional level. It's just nice to put something like that down. Does that answer that question?
Yes, it sure does. Thank you.
Okay, and I can see if I can include a resource too with our other resources that just gives an example of one of those visual schedules.
Perfect.
Okay, so enhancing agency and identity development. This is really directly addressing the problems with coercion and learned helplessness. So we need our clients to have buy-in and to want these changes because they want to have a better life, not because they don't want to be inconveniencing their support people anymore. We want them to have positive psychology traits, euthymia and positive self-esteem. So when we're teaching people how ERP works and we're giving them the rationale, take the time. You guys know about enthusiastic consent when it comes to like sexual health. When we're doing mental health stuff, let's get enthusiastic consent, enthusiastic informed consent for the way that behavioral psychology works. If we don't, let's either spend more time on it or let's try something else. How do we use positive reinforcement? When we are trying to get consent for doing difficult things, we will often build in positive reinforcement, and it can be kind of a nuanced thing where we don't want to coerce someone, but also we do know that it's helpful. I'm going to address that in a later slide, but we'll talk about how positive reinforcement maybe gets in the way or doesn't get in the way of that agency piece. Offer treatment options without guardrailing or ableism. So that means offering ERP, offering ICVT, letting people know what's available, and things like EMDR for OCD. I've really looked at the EMDR research for OCD, and I see very poor quality in it, where all the studies that I've seen started meds at the same time as the therapy, and you can't discern any difference between the two. So until they're really doing good comparator where it's EMDR versus ERP with no addition of meds, and I'm not going to say there's any quality there. But nonetheless, I offer everything that I know to my clients. I might give my professional advice from experience, but I don't keep people from doing what they think is going to work best for them. So no guardrailing, but also no ableism in what they have to do either. Collaboratively choosing treatment goals. So if we're talking about a behavior that they want to change or that their system wants them to change, we're going to always be asking these questions. Does the behavior cause distress or impairment? And then we're going to ask questions about ableism within that, about is the impairment something that we're expecting a person to climb Mount Everest every day to do the same stuff that holistic people are doing? And then is rigidity about this behavior the source of distress or impairment? Maybe it's not that we need to completely extinguish the behavior or find a different functional way for them to cope, but to understand where the rigidity comes from and just get the person to loosen up about it, where we're not really doing ERP about it. We're doing humanistic or motivational interviewing. Discerning the adaptiveness of stimming. So particularly when we are trying to think about if a stimming behavior is one that we want to try to reduce or not. So first off, we want to ask about, is this OCD or autism? And then if it's autism, people want to jump to, so it's got a function, so we shouldn't be reducing this at all. So I think we need to ask a question about discerning adaptiveness of stimming. Does the stimming interfere with corrective learning about fears? Am I doing the stimming during exposures in a way that my brain is explaining away my safety by the fact that I have access to my stim. Does doing the stim demand excessive attention? I'm not really paying attention to the exposure. I'm paying attention to my stim, and it's in one ear out the other, so I don't really have to face it. It's like white knuckling, but without all the stress of it, but I'm still not really engaged. Does it promote misattributions during the learning experience? It's that same thing I'm saying in the beginning. It's interfering with the corrective experience. And is it rigid or excessive? And who gets to determine that? Hopefully our clients are determining that, but also our clients have to live in an environment where, they have to take in practical considerations. Someone wants to be in a mainstream classroom. They want to verbally stim. It distracts all the students that are around them. They may have an option between their verbal stimming and their mainstream classroom, or at least have to find some middle ground there. And as we're trying to get this positive identity development, let's try, as we're giving language about how ERP works in psychoeducation, that we're not leaning too heavily on ERP is all about you can never know yourself, you can never know what's going to happen, you have to accept uncertainty at every turn. A lot of autistic people have these experiences where they've been invalidated over and over again and their self-trust is lacking. Let's find language about ERP that says we're going to be doing things trusting ourselves. The reason we're doing it is not because we are accepting uncertainty about it, but because we trust our common sense, we trust our past experience, we trust our own perception in this stuff, instead of rigidly accepting uncertainty. In OCD therapy, reassurance often gets called compulsive, and it can be. If I say, you told me that the world isn't going to end yesterday, but I need you to tell me again today. And they say, come on, it's not ending. And I say, no, that's not how I need it. I need you to say, the world is not going to end. Okay, the world is not going to end. No. I need you to say it the way you said it yesterday. Say it like this, the world's not going to end, right? That is compulsive reassurance. But I got bullied at school again today. Tell me I'm not a bad person. That is not compulsive. That is the kind of support that our autistic kids need. Even if they've got social anxiety, even if they have OCD about what people are saying about them, we want to help them build positive identity through praising them and reinforcing their positive self-concept. So I asked the question at the end of this slide about, is ERP like doing a push-up? This is a debate that I frequently have with a prominent researcher and clinician, John Hoffman, who does the Neurobehavioral Ranch in Florida, where his big point is you just get better at facing these stressors as you do it. And I say, no, distress has to reduce. I'm not just getting stronger and stronger and stronger until I can lift the weight of the world. We have to take some of the burden off of your back. So my experience doing ERP with clients is not that just that their ability to tolerate gets stronger, but it's that new insights and desensitization makes the load they have to lift easier. I think it's valid to work on both sides of it, but I don't ignore the side that says that we're supposed to desensitize, even though some of the big autism centers out there don't worry about it so much. I have to think he probably sees all of folks who are, absolutely at their wits' end, where they've tried everything else. And that's why it seems like folks don't really reduce in distress to him, because he's trying to help save people's lives and let them function in their community without having to be in a more restrictive environment. And I think that probably both of our experiences probably impact where we come to that discussion from. So do we accommodate or do we intervene? I have this reference in the references. This is a nice flow chart. I think y'all understand the basis of where I'm getting at with this stuff. This slide is about discerning stimming, special interest, sensory sensitivity, and emotional intensity from OCD. So stimming is the pleasant use of sensory input to regulate emotional hyper or hypo arousal, and it can be confused with compulsive touching or ritual movement or neutralizing behavior. That's not the function of it. It's going to help people over the long term. special interests are this product of monotropism, where people have a hyperfixation that becomes really central to their identity. And it's really valuable for positive self-esteem and stress regulation through their life. But this could be confused with the colloquial use of the word obsession. He's so obsessed with race cars or whatever it's going to be. Or it can be compulsive perfectionism about why they're engaging so much in their special interest. Oh, you need to get it perfect. Actually, no, I just really enjoy engaging in this. Or hoarding, or aversive motivation. The reason they're talking about their special interest is because they're running away from something that we're trying to make them do. And that's not always the reason. So if someone's ever trying to use ERP for, you're not going to be interested in this thing anymore, man, that's way off the mark. And sensory sensitivity is the experience of being harmed by stimuli that are not perceived as averse by the neuromajority. And this reflects a neurological difference. It's only partially going to desensitize with repeated exposure. There's some folks who say that sensory sensitivity doesn't habituate at all with repeated exposure. That's not my experience. I know a lot of occupational therapists who have a completely different experience, especially around some of these little kids where we've seen like the tactile brushing. It's pretty hard to argue with that evidence. That's not coercion. That is real desensitization. But there probably is some truth to the fact that when desensitization does happen for allistic or autistic clients, it's probably happening at a slower rate for our autistic clients. I didn't have a good resource for that. I would have loved to put a citation on that, but I couldn't find that one for you. That one is more popular knowledge in my sense. So if someone wants to email me a citation that they really like on that one, I would love to see that. I just see it recommended often in these and in my own experience. And then lastly, like emotional intensity about things like injustice or grief or honesty or predictability. These are really common in autistic folks, but they can get blamed on OCD, where they've got these rigid beliefs about recycling because they have anxiety about the end of the planet. They've got this like intolerance of injustice because they think something awful is going to happen. It's not always like that. Sometimes it can just be, how intense people feel emotions, and we got to respect those kinds of things. So ERP that targets any of those traits is going to be at best ineffective in its goals. And at worst, it's going to foster that learned helplessness and identity rupture in our clients. So we're saying that exposure helps people because they don't escape from distress, but these autistic traits or behaviors, these are things that allow people to feel better, right? Stimming isn't always done when someone's distressed. Sometimes it's taking a neutral situation and making it feel good. But plenty of the time, I'm doing that because I'm in a situation that is distressing, or I'm taking a break from a situation that's distressing. And special interest, when I engage in, it's regulating, but it does allow me to escape from the aversive stimulus. So how do we navigate that? With common sense. Be a clinician and not a technician. Talk to your clients, be honest with yourself, push the amount that you negotiate with the client that you're allowed to push, but don't guardrail them away from exposure therapy because you think that pushing them to let go of some of this stimming stuff. Sometimes it's going to be helpful to allow them to feel distressed. Other times, this is going to help people stay within the window of tolerance. And man, I don't have like a perfect answer. It's not like you can eliminate this stuff. Let's say eliminating all of this coping stuff would help people learn distress tolerance better and get rid of their OCD better. Yeah, but it would have this consequence of harming them in all these other ways throughout their daily life, even though their OCD is better. So when we don't have a good answer, well, it also means we don't have a bad answer. So we're going to navigate those two. When people complain that they don't want to work with autistic clients, often what's going on is something from that last slide was being treated as anxiety. And they're saying they're not letting go of this thing, and I don't know why it's so hard. But from Paul Collins's book, Not Even Wrong, I really like this quote. The problem with pounding a square peg into a round hole isn't that the hammering is hard work. It's that you're destroying the peg. It is harming the client to try to fundamentally change them in those sorts of ways. So let's be good. Let's be discerning about our functional assessment. Okay, next point is, what do we do about the slower processing that we often see in autistic clients and the slower pace of habituation? So longer processing time might mean that sessions actually need to be longer. So visual schedules, like I was talking about before, those are often suggested to try to cut some of the fluff in the session and cut some of the distraction so we can keep our session to that hour-long time. But as we were saying before, it can take people away from their identity and their info dumping and what's important to them. And it can make people feel coerced and controlled and like their relationship is suffering and like their identity is suffering. So we don't often consider the option of let's do longer sessions. Let's do 90-minute sessions. Let's do 2-hour sessions with our clients who really need it. Let's meet twice a week, especially when we're worried like, oh, our client definitely can't afford this. Bring it up to them, see what they can do, make the suggestion. If they get more out of each session, it may be a money saver for them in the long run anyway. So visual schedules can help, but spending more time is more valuable. I find this one to be like one of the more ableist things. Like autistic people have longer processing times. So if they just do this extra work, then they'll be able to get as much done as everyone else in session. Plus this extra thing, doesn't make sense to me. Let's extend our sessions. I like that better. We'll probably do a lot of repetition of psychoeducation and rationale. If you read Edna Foe's book about how to do ERP, you start ERP in session 2. You get through psychoed and treatment planning and you jump right into it. With our autistic clients, we might build a lot more rapport and we might explain the rationale to get that buy-in a lot more times. Sometimes I'm not starting ERP with folks until like way late in it. I mean, I'm embarrassed. I shouldn't be embarrassed as I'm advocating for this, but I recently started with someone on session number 26, and there's supposed to be 26 sessions in like the extended ERP protocol. So we like didn't even start the actual mechanism of action until we were supposed to be done with it. But that was because my client would have been white knuckling and would have been coercive, and they didn't care. It was all me wanting it. And over time, as we just like talked about, eventually they shifted in their belief and they wanted it. Similar to that, it might take more time to build up motivation before exposure trials and more time to regulate after. So it's like in session, we're going to spend 5 minutes, on hi, hello, 10 minutes on what happened in the past week, and then 30 minutes on our exposure thing. It might take the person 20 minutes of psyching themselves up to do the exposure. And some of that stuff we were doing in the beginning wasn't really helping. It was just getting me to distraction. They might need quiet time. They might need time to stim, self-regulate, journal, do a thought record, read something that's been inspiring to them, talk to a support person on the phone. That would be seen as avoidance, but if it's what allows our person to have agency, is totally worth it. And same with time to regulate after. In ERP, we're teaching people a lot of distress tolerance. If their distress doesn't come down, they can still learn quite a lot about their ability to tolerate distress. And it's not unheard of to send someone out to the waiting room while their SUDS rating is still 9 out of 10, because they're like, I'm fine. I feel the distress, but I've felt this distress over and over and over again, and I'm fine with feeling it. Our autistic clients may not be okay with that, and they might need a long time to come down from that. So we don't want to do exposure up to the last minute of the session with someone who takes 30 minutes to come down. They can wait in the waiting room before they leave or things like that. But they would probably prefer to have time debriefing and consolidating learning with their therapist. So also in ERP, we're often shooting for a reduction of that SUD score by about 50%. Well, for an autistic client, maybe we want to do repetition until we get down to like near zero. We get down to boredom. And that is ensuring that things are more tolerable and the distress is less. And because it's taking people a long time to make that progress, maybe it makes more sense for us to be more cautious and make sure that we've beat one piece of OCD at a time with this hierarchical way of getting everything down to low distress. Now, some things in life just are not low distress, but touching a doorknob can be. Also with slow processing, clients might not know what they learned until a long time after the session. So sometimes clients will kind of have like a blank look on their face after doing the exposure. And they're like, I don't really know what to make of that. I don't try to convince them that everything was great. I'll provide the rationale, but I'm not going to argue with them and try to convince them. That'll just inoculate them against the possibility that they grew out of this. It'll give a weaker form of the argument that they're going to learn to argue back against, so that when they could come up with their own argument about this, how this has been helpful, they'll already have this strengthened counter argument against it. So I'll give people time to sit and think and process. And you get surprised that sometimes it's like, we did this exposure and I'm like, oh God, that was too hard. And then we come back and we do easier exposures after that. And then we're getting to termination and we're like, okay, so you're doing a whole lot better after all of this ERP that we've done. What advice would you have for other people who are coming in? What did you learn through this process? What was the most important piece of this treatment for you if you were going to share it with others? And a lot of times they'll bring up what that really difficult thing was, and they'll have a very different telling of the story where they felt this overcoming of it. You can think about in our relationship with a therapist that just like in any other relationship, healthy relationships have somewhat of a positive illusory bias where we kind of gloss over some of the negative and we remember more of the positive. It's very evolutionarily adaptive for us to like stay safe within groups, to not just like, you know how our mind wants to mental filter about all the problems. Well, socially, we also are going to attribute some positive things to people that we have that kind of closeness with. So let that process happen and let their remembrance of what happened during it kind of dull out some of the awful details and enhance some of the more powerful positive details. I mean, I just remember I have two kids. So when their mom gave birth after the first one, it's, how would you ever go back and do that to your body again? And the answer is like, you kind of blank out some of the most awful parts. You know that it was awful, but a lot of people just can forget and not think about those things. Some of that happens, and we can let that process enhance the learning that comes. We don't want to force it. And I haven't talked much in this presentation about when the child is not involved in treatment and we're doing the supportive parenting for anxious childhood emotion space approach. But when we're doing space or using stimulus control, we're not giving the person an opportunity to do their compulsion because we're like taking away what they needed to do their compulsion. We are giving them valuable learning opportunities, but we're also coercive. There's just no way around it in that. It is just literally coercive in that case. So should we ever be coercive? I think the answer is we have to use our judgment. And yes, sometimes if it's health and safety, if it is something where like you have a great relationship with this person, you have agency in so many ways in their life, and you can get some buy-in that I think this is good for me, even though I don't want to do it. And you can see how their parts are ambivalent about it. You can bring in more of that coercion against the part that is against this process. But that's always a challenge. When we do face problems with like they're just not getting it, or it's taking too long for them to get to this step and it's just not going to get there ever, and sometimes we think about bringing those measures in. We want to always involve caregivers and support persons in ERP, but especially with autistic clients. We need the family's insights because our clients don't tell us everything that's happening. They don't always understand why things are the way that they are in the family. We can treat families like clients as well, because everyone is suffering when someone has OCD and like we're all living by these rules that are so awful. Everybody is suffering. So let's bring them into the session and help everybody if we can. We bring caregivers in to support our client while they're doing their homework ERP. So support persons are going to like do some help with executive functioning and having a conversation about how things went. So we're reinforcing learning and not just being all alone thinking about it. Bring that support person in session so you have consistency about how they provide that support and how they talk about ERP outside of sessions. Inclusion of support respects the client culture and reduces the dependence on experts. we have this expert role as the therapist, but these behavioral learning principles are not so complicated that only a therapist can understand. And there's a lot of wisdom within families. I mean, so much of this boils down to, if you're afraid of it, you got to face it, or you're always going to be afraid of it. You know, Western medical culture is not the first culture to make that up. So you don't want to foster dependence on therapy. You don't want people to think that they can't trust their own judgment and they need their therapist to tell them what's OCD or not and what every response prevention plan is supposed to be. So bring in their families so that they're not outsourcing that authority to you so much. And as we know, reduction of the support system, accommodation of obsessive compulsive symptoms or anxiety and distress tolerance is almost always a crucial part of ERP, where there's ways that people who live with your clients are facilitating their compulsions, enabling avoidance. And that's almost always something that we have to address directly with their support system instead of with the client. And there's often a positive reinforcement program. So in the CBT for autistic youths with OCD literature, it is considered a core element of research-backed ERP with autistic kids to have some sort of a positive reinforcement program. Negotiate that with the parents in the session, be collaborative about that. And also, the family actually may need to be the one to change before the client changes. You bring in your client, but the family might have to change first because maybe we're doing the space approach and the client really was resistant. They didn't want to change. Maybe there was so much executive function challenge that just working one-on-one with the client, like they weren't going to be able to do it on their own. They were going to need a lot of scaffolding within the household to be able to do it. And we need to make changes in the family to create that scaffolding. Or also this like not even wrong concept where autistic people feel like you're asking me to do something for everyone else's convenience, but I'm not wrong. You're telling me to change and I'm not wrong. And so just like with PDA people, we use this term leveling around everyone has to be sort of like on the same hierarchy. No one gets to be the boss and get all their needs met and determine whose needs get met or not. And so we'll see someone who's in that lower in the hierarchy position do this leveling attempt of trying to gain control of the situation. And we can like allow that to happen a little bit. We can make the family make some changes about allowing stimming, for example, if the autistic person is going to be asked to reduce their OCD. Okay, my last slide here. Autistic clients are almost without exception frustrated by that not even wrong thing. It is hard to sell the rationale for ERP if the client's avoidance is for a subjectively good reason. So motivation for ERP has to be, it makes sense. I'm not going to be able to sell the rationale if it's this not even wrong experience where it's like, this is a good reason for me to do this. ERP isn't going to work if I'm not able to like learn anything because I already know that all I'd be learning is like my needs don't matter. This gets complicated, as all things with this intersection will, when we see these egosyntonic OCD symptoms. So egosyntonic versus egodystonic. Egodystonic, we often say about intrusive thoughts. If someone got a thought that maybe they're going to harm someone they care about, and they say, oh my God, does that mean that I'm a harmful person? And we say, no, that thought is egodystonic. It doesn't fit with your ego, with your sense of self. Well, in autism, there always is an egodystonic part if it's OCD, but there might be a lot of egosyntonic stuff around it. So you can imagine someone who is very neurotic. They really like a clean space. They really like things predictable and put away and absolutely in the same place every day. And it helps regulate their nervous system. And so then they start a cleaning and putting away ritual. And it goes beyond that egosyntonic tidying and ordering that other people might have criticized them for, and starts to be like, I don't trust myself that I really wiped this surface well enough. I don't trust myself that these things are organized. Let's unorganize them and then let's make them symmetrical. Oh, let's do it again. Its symmetry doesn't feel right. Right. So we can get those. I'm not egodystonic. I'm egosyntonic in how I'm doing the organizing. But then once I stop trusting myself, now it starts to feel more and more distressing. Those are the ones we want to go for. If you're getting a lot of rigidity about, I'm not wrong about this, I don't want to change my behavior about it, find what piece of this is ego syntonic and try to leave that alone, and find what piece of this is ego dystonic and help the client understand where they're doing things that they don't even agree with. And that's your in. Whenever we are choosing a avoidance target, we will do better if we are prioritizing like reclaiming something I used to love and now I say I hate and avoid, rather than novelty. So, you know, in terms of like, you want to do the ERP because don't you want to get this? Don't you want to have this reward? Instead of suggesting novelty, try to find those things that they used to love that it seems like OCD has gotten in the way of. So yeah, find what they want to do, but they don't think they can have because OCD makes it too painful. Find a slow path to that goal. So it's not, I want to go to prom. It's, I want to go to Comic-Con, and it takes the same skills to get there. But if I say, well, we're trying to learn social skills because prom is coming up, I'm not getting the same buy-in. So find what they want and they don't think that they can have. And then the platinum rule is contrasted to the golden rule. The golden rule is do unto others as you would have them do unto you, meaning assume my preferences are the same as everyone else's preferences. So if I'm treating others the way I want to be treated, then they're probably happier for it. And sure, that's much better than treating others cruelly. But platinum rule is treat others the way they want to be treated, understand their subjective experience, and treat them that way. So that's how we're trying to come up with our reinforcers. We can incorporate special interests into session. This is a form of positive reinforcement. It goes better when the incorporation of that special interest is really a shared thing, a shared vocabulary. Like you also watch the anime, not just you let them info dump about the anime. Even if that means you spend a couple minutes on ChatGPT getting a summary and finding the one thing you're actually interested in and actually curious about, that can be helpful for that. And it helps build our shared vocabulary. Like we were talking about, a common place to use it is in that SUD scale, to use a special interest there. 10 minutes of info dumping at the end of the session could be a really helpful reward to keep people engaged. Or it could be like, I want to go home. I don't like you that much. You're not actually into this. I come to you for help with these emotional things. Don't make me info dump to you. And then in those cases, the client info dumping, they might look like they're lit up because they're talking about their special interest, but they're really lit up because they're avoiding the last 10 minutes of session. And if you were going to say, hey, you could actually go home now, and they prefer that, that would be just as good of a reinforcer without doing any of the like infantilizing and, oh, you're so cute because you have a special interest stuff. I don't see a lot of autistic clients complain about it, but I do see a number of them complain about the infantilizing stuff. Yeah. So further, when we're using any form of positive reinforcement, including a sticker chart or getting a reward or using a special interest, we want to think about how it's working. So if I'm training a rat to press a lever using behavioral principles, it doesn't go sniffing around the cage if it's got a belly full of food. If there's a big pile of food in the middle of the cage, it doesn't look for the lever, it goes straight for the food. So when you're trying to train a rat to press a lever, the first thing you have to do is withhold food for a while so it's hungry and it has some urgency to go sniffing around and pushing on things. I don't do this with humans. I'm not okay with that. I think that reinforcers that are food pellets that are necessary for survival include things like sensory safety, access to special interest, maintaining attachment with support people, having some amount of downtime so that you can re-regulate. This is not a reward. This is the basics that people need to be okay. The rewards are the bright, shiny thing. It's the donut, not the food pellet. It's the trip to Disney World, not the ability to play the video game that you play every single night before you go to bed for 30 minutes that helps you connect with your identity. And then I'll make this comparison here that it's like grooming. When people when adults offer children these reinforcers to gain special trust so that they can do things that the kids don't feel okay with, when we're giving a lot of positive reinforcement and the kid doesn't feel okay with the exposure, they're not entirely different. There's a degree of benevolence, obviously, in ERP, but it doesn't have to be, because we've just been talking about how coercion and control can be a big part of this. So I think that there is merit to being very wary of how we use positive reinforcement, so we don't end up inadvertently grooming the people that we support, that they should like us even though we're treating them poorly. And finally, highlight progress, celebrate small successes, the same stuff we have to do with everyone. People might need more of that and more frequent when their identity already makes them feel a sense of shame around their symptoms. Okay, that's my talk. Thank you so much for everyone's attention today. Here's my email if you want to shoot me any emails. I'm happy to respond or have a conversation afterwards. And I'll stay on here for a minute. If anyone has any questions, I'm happy to take a shot at answering.
Yeah, absolutely. So this is awesome and super helpful. Let's see. I think, Jeremy, can you unshare your screen, maybe?
Yes. Am I still shared?
Oh, now you're
I
not.
think I'm
You're
unshared.
perfect. Yeah.
Okay.
Okay. Awesome. I had so many questions, and a lot of them, of course, you kind of answered as we were going through. I really appreciated that emphasis on the how did you say that? Egosyntonic
Egosyntonic
and
versus
dystonic.
egodystonic.
Yeah. And so, I think one of the questions I had was just to elaborate a little bit more on the positive reinforcement. It's interesting that you mentioned it, calling it kind of compared to grooming, because I feel like that's kind of where we start getting into some of the ABA stuff, and it gets really tricky. Like, you want to do this, but you got to get the buy-in. What are some effective types of the positive, like you mentioned, like the info dumping at the end, like saving that for the end of the session and kind of even just using that as some positive reinforcement? Are there some other things that you can think of that maybe it involves, again, that caretaker or something that they could self-regulate?
Yeah, so thinking about how to prevent it from being grooming, I think mostly about don't be that dangerous person in their life, so that you are the positive relationship you're building is a beneficial relationship. And that's first and foremost. What kinds of reinforcers do we end up giving? It's Xbox time. It's save up to get a ice cream trip for the family at the end of the week. It could be, if you graduate and we've got this score on the Y box, we might go to Disney World. I mean, you can do stuff like that. It's anything that's bright and shiny.
Yeah.
Yeah.
Just whatever it is for that person. Absolutely.
And also,
Other,
we're giving praise throughout. We're using
yeah.
the therapeutic relationship, and as much as we can make the motivation intrinsic by providing the rationale, we want to do that and not rely on the reinforcers. But that external reinforcement is very much an evidence-based part of this, so I don't want to neglect that and say it should be all intrinsically reinforced. I do the IOCDF Special Interest Group for Autism and OCD, and we had a meeting this Monday, and one of the questions that was asked was, what happens when you're working with someone and they're transitioning from childhood into adolescence? How might you adjust your approach? And a couple of commenters were saying about more intrinsic motivation and having more agency in this decision making. And then one of the experts, a mom of an autistic adult with OCD, who's also a consultant for the Canadian government, she says, well, I just have to completely 100% disagree with that. And in my case, what we needed to do was not start treating him like giving him enough rope to hang himself. There's no one size fits all response to any of these things. So yes, intrinsic motivation, the best. Sometimes we can't rely on that.
Yeah, I love that. Any other questions that anybody has? Feel free to unmute if you've got something. We've got maybe just like one more minute here before we wrap up. I did go ahead and put the link in the chat for you. So if nobody has anything, we will go ahead and kind of wrap up. I just want to thank you again, Dr. Schumann. I mean, this is super helpful. For anybody who's watching this, if you haven't watched Jeremy's previous training that he did for us last February, it is, of course, in the resource library, so you can go back and get your self-study CE for that one if you're watching it. And Lisa, is the link not the correct one? Did I put the wrong link in there? Let me click on it and see. Oh, I sure did. Let
Yeah,
me
just
find the
seeing
other
the
correct link.
certificate only one. I'm not
Yeah, yeah,
seeing
yeah.
the
That's okay. Thank you for that. I appreciate
Sure.
that. Hang on, let me see here. I will get the correct link. Here it is. That's what I get when I'm trying to, I just copied and pasted the wrong thing. Okay, this, okay, try that one, see if that one works. Yeah, that's the correct one. Sorry about that. Okay. And so just a couple of other little housekeeping things. Our next event for the Therapist Hub, we have our live consultation group on Friday, the 19th of September. We're in September already. So that's at 11 a.m. Eastern, 8 a.m. Pacific. And then our next live CE, which is the first Friday of the month in October, October 3rd, we have a session on using internal family systems with neurodivergent clients, which I think will fit nicely with all of the other conversations and work that we are doing. Again, thanks again, Dr. Schumann, and thanks everybody for being here. Thanks everybody for watching later, and we'll talk soon. Have a good one.